Western diet high in saturated fats. If you were on the Mediterranean diet, the chance of you being alive 5 years later was over 90%. But if you continued your Western schmaltzy diet, chance of you being alive after 5 years was 80%. Next. In the 1980s, we at St. Paul's Hospital participated in a study with the University of Washington, studying people who were randomized to either a regular diet or a diet of low in cholesterol plus taking a statin. This is a coronary angiogram. In the top picture, in the middle, you see a big blue arrow showing a near blockage of that white artery. 3 years later, in 1987, the artery is nearly normal, and the artery at the top, which had the small arrow, is now opened up. So sometime you can improve your coronary disease. It may regress with diet and or a statin. Next. If you go to Palm Springs, you'll see different guidelines for high blood pressure. But in Canada, the new guidelines indicate that a normal blood pressure should be less than 135/85. Or if you're like the lady in this picture and you're having a device put on and monitored for 24 hours, the average of that 24-hour reading should be 130/80. If you're diabetic, your target is even stricter than the regular person at the top. Your target should be less than 130/80. Next. So, non-medical ways to lower blood pressure include weight loss, a DASH diet, which is low sodium, low fat, and high in nuts. Further information about the DASH diet can be obtained from the Mayo Clinic website. Limit your alcohol intake to less than 2 drinks a day. Have moderate exercise, as we'll hear from Dr. Isserow. Try and get some relaxation technique, meditation, yoga, or even davening. Next. In 1949 and 1950, 50,000 Yemenite Jews were airlifted from Yemen to Israel on Operation Magic Carpet. What was found is that their descendants later, who were eating more of an Ashkenazi diet and more sugars, had developed diabetes and coronary disease, which was not seen in their parents. Next. So in summary, I'd like to remind you the importance of smoking cessation, following a moderate and rational diet, attempting weight reduction, moderate daily exercise, only Bernice does the Peloton, and stress reduction. Next. I'd like to thank JNF for giving me this opportunity today to participate in this very important panel in Vancouver. I'd also like to thank JNF for giving me the opportunity many years ago when I was a university student planting my tree for JNF in Canada Forest outside Jerusalem. Thank you very much. I'd like to now introduce our next panelist. Saul Isserow is a fine human being, but he has an outstanding reputation as an excellent cardiologist, being trained in South Africa, having practiced as a general practitioner, and he is an outstanding teacher. In 2019, he was awarded the Killam Prize for teaching and was the only person in the University of British Columbia Medical School who received that prize that year. Saul, take it away for exercise, please.
Thank you, Art. Thanks a million. Can you hear me, Art? Just give me a thumbs up if you can. Good. Thanks, everyone. Art, thanks for giving me an easy subject. You know, if I had to say to anyone, I want you to do something that's going to lower your risk of a heart attack, lower your risk of a stroke, reduce your risk of certain cancers, breast cancer, prostate cancer, improve your sense of well-being, well, you'd all take that, and that's exercise. So it's a given that exercise is good for you. What I'm going to discuss in the next 4 minutes, and then leave the difficult questions to Zach and Josh, if that's okay, Art, is discuss how much exercise we need to do, what's probably the best time to do it, and whether there are any risks and how exercise actually works. So the first thing is, how much do you have to do? Do you have to go do the Peloton every day and go up grass grind? And the reality is the best bang for your buck you get from a cardiac point of view is simply getting off your tochus and exercising and walking for 30 to 40 minutes a day. By far, that does the great majority of the benefit from a cardiac point of view. It's not to say that more isn't better from an aesthetic point of view, from a socialization point of view, from a mental well-being point of view, but from a purely cardiovascular point of view, getting off your backside and walking for 30 to 40 minutes a day gives you the great majority of the benefit you're going to get from the heart point of view. And that's because there's a common misconception that exercise strengthens your heart. That's bobomyces. It just doesn't. It doesn't make the heart any stronger. Think of the human body like a car, and what exercise does is it makes the car more fuel efficient. It doesn't make the gas tank any bigger. So what exercise does is it improves the oxygen extraction by the muscles. It improves the environment the heart lives in, lowers the blood pressure, lowers the body mass index, that kind of thing, but it doesn't actually make the heart stronger, but it certainly improves the environment the heart lives in. The next question is, can you do too much? I have people who are coming to me all the time saying to me, can I do the grass grind or can I do the grand fonda? And if I were to ask anyone which exercise is associated with the highest prevalence of heart attack, which exercise do more people have heart attacks than any other exercise? And I think a lot of us would answer, I don't know, cross-country skiing or triathlons. The reality is the answer is lawn bowls, all right? And the joke about that is obviously it's not that hard to bowl a little white thing against a little kitty to try to get that little kitty. It's clearly that they're altacuckas playing lawn bowls, all right? So it's not the fact that the activity is dangerous or not dangerous, it's the person doing the activity. So the question always is, not are you safe enough to ride the Grand Fonda or go up Grass Mountain, but are you actually safe enough to play lawn bowls? And the reality is that one cannot outrun or out-cycle or out-yoga or out-bar your coronary risk factors. If you've got hypercholesterolemia, high cholesterol, you've got untreated hypertension, all the running and all the cycling in the world isn't necessarily going to negate that risk factor. The last thing I'll discuss, Art, because I know it's only a limited period of time, is what's the best time of the day to exercise? And we're studying that at the moment. I actually think the answer is going to be that time of the day that you can do it and that's easy to fit in. And a lot of us, it's the morning because you can predict what's going on in the morning. But the reality is there are more heart attacks early in the morning than any other time. There are actually more heart attacks on a Monday morning than any other day of the week. And clearly, to have a heart attack, one needs to have an underlying predisposition, underlying coronary artery disease, and then a trigger. And one of the triggers may be before one gets up in the morning, there's increase in adrenaline and cortisol and that kind of thing. And we're studying whether or not there's actually a high incidence of having a heart attack if you exercise in the morning compared to the night. I don't think we're going to find that. I think we're going to find that whatever time of the day you can exercise and it's not an added stress to you, that's probably the best time to exercise. The last thing I'll leave you with, Art, before you get on to the far more trained younger physicians on our panel, is even though that we think that we need to treat high blood pressure and high cholesterol with medications on occasions, the reality is the next time you get a script from your doc, leave it at a friend's house a couple of miles away. Walk over to your friend's house, have a l'chaim with your friend or a cup of tea if that's what you want. You'll probably get as much benefit out of the walk over there, the social interaction with your friend, as you will from the medication. So Art, I'll leave it at that. I'm sure there'll be a lot of questions later on.
So thank you very much. You know, your relaxed demeanor is so good. I'm going to recommend you for CNN. You're fantastic. Thank you so much. Zachary Laksman. I had a friend who had an ablation study by Dr. Laksman, and she came to me, she says, Arthur, he looked like Doogie Howser. I said, look, he is a very well experienced guy. As a matter of fact, He has 4 young daughters. Dr. Laksman is an electrician who works inside the heart. And besides the special skill, he is a very unique person holding a professional investigator award from the Michael Smith Foundation. And as you know, Michael Smith was one of the few Canadians who was holder of the Nobel Prize. Dr. Laksman runs the atrial fibrillation clinic at St. Paul's Hospital, UBC, and Zach is now going to talk about living better electrically, atrial fibrillation. Dr. Laksman.
Great, thank you, Art. What a great honor it is to be on this panel for such an important cause. So thank you very much. I'll talk to you today about living electrically as well as you can. So next slide, please. So I'm going to talk to you about atrial fibrillation. And the reason is that this is the most common heart rhythm disorder across Canada and across the world. And you can see on this graph on the right, if you're fortunate enough to live into your 80s or 90s, then 1 in 4 of you is going to develop atrial fibrillation. So you're going to see it and you may have to live through it. So next slide. What is atrial fibrillation? Well, this is a simple picture of the heart. Doesn't look so simple as it's beating. There's an electrical light switch in the top, and that's going to tell your heart when to beat. And that signal goes down a wire and tells the bottom chambers when to beat. Next slide. And we'll see that on the right, you can see that when you're in atrial fibrillation, there's irregular impulses, electrical impulses in the top chamber of the heart called your atria. And when those go down the wire that connects your top chambers to the bottom chambers of your heart can go in a very fast and a very irregular, chaotic pattern. Next slide. This is what we see when we map the heart going from normal rhythm to a very chaotic rhythm. So we see very irregular, chaotic electrical patterns that we're trying to map when we're doing a procedure on the inside of the heart. Next slide. So where does atrial fibrillation come from? Well, atrial fibrillation has a number of causes, the most common being age. As we get older, the risk increases. Certainly our genetics, what we're born with, the DNA that gives our instructions for how we're built, and in some ways how we act, that has an important impact. As Saul mentioned, sometimes too much exercise can be a problem, but we're talking about really intense endurance exercise. Stress, medications, even pollution, and certainly bad habits, alcohol probably being number 1. Next slide. You might wonder, what does atrial fibrillation feel like if you're thinking you might have atrial fibrillation? Well, it can present in a number of different ways, from feeling unwell, fatigued. Some people describe heart racing or palpitations. It can just be a change in your exercise capacity. Before you could walk 18, now you can only walk 9 holes. The scary thing is that sometimes atrial fibrillation can be completely silent, and you might be unaware that you have atrial fibrillation. And that's a problem because atrial fibrillation substantially increases your risk of stroke. That irregular rhythm in the top chambers can lead to blood pooling, and slow blood can clot and then get sent to the brain and cause a stroke. Next slide. So you might be thinking right now, do I have atrial fibrillation? How do I know? Well, probably the most important thing you can do is learn how to take your pulse. If you can feel on the thumb side of your wrist, there's a large artery, and that artery will give you an impulse. And if that impulse is nice and slow and regular, you probably don't have atrial fibrillation. If it's very irregular in terms of the strength of the impulse or in terms of the rhythm, that's a time to see someone and get an electrical heart picture or an electrocardiogram. And that's this middle picture. That's called an ECG. That's really the gold standard in telling us if you have atrial fibrillation. On the right, you see wearable technology, an Apple Watch that can detect atrial fibrillation both when you're thinking about it and when you're not, and can even record a very simple ECG. The thing to know is that these aren't perfect. So there's a lot of false alarms that cause a lot of anxiety for you and your cardiologist. Next slide. So what do I do if I have atrial fibrillation? Well, I'm not going to go over it because Dr. Dodek and Dr. Isserow really gave us a good overview of how to live a healthy, heart-healthy life. And that's what your cardiologist or general practitioner is going to help you do. It's certainly our focus in the atrial fibrillation clinic, looking at the holistic totality of your heart health. Next slide. The pillars of atrial fibrillation care are stroke prevention, sometimes requiring blood thinners. Sometimes your doctor may try to slow your heart down. That's called rate control. And sometimes their focus will be to get you back in a normal rhythm, and that's called rhythm control. Last slide. But probably the most important thing about your atrial fibrillation care is that it's personalized, it's tailored, it's for you. So really it is a conversation between you and your doctor, and hopefully you'll have a doctor as handsome and as experienced and as brilliant as this one right here. So thank you very much and all the best.
Zach, thank you so much. You know, Zach, once I was asked to give my best 45-minute talk, coronary angioplasty versus open heart surgery, in 12 minutes. And I said, I can't do it. And it turned out to be my best talk. That happened to be the best 5-minute talk I've ever heard on atrial fibrillation. Friends, Dr. Laksman has simplified for us a very, very sophisticated topic and presented what it does and the risks. And thank you so much, Zach. That was outstanding. Our next speaker is a cardiologist who now practices at the Royal Columbian Hospital. Dr. Joshua Wenner has had his education between University of British Columbia, University of Ottawa, and Stanford University. He practices critical care cardiology. But one of his secrets that we're going to release tonight is that he is a third-generation medical practitioner. His mother is Dr. Gail Wenner, and his grandfather is Dr. Morton Dodek, who we believe is listening somewhere out there tonight. So Josh, if you have all your family around you, you're ready to go. We are ready to hear your presentation on COVID. Does it affect the heart? Dr. Wenner.
Thanks, Art. Can you hear me? Thumbs up?
Yep, we're good.
You know, Saul and I had joked ahead of time that we were just gonna make that the intro, so it's kind of funny. Meanwhile, you know, Saul and I had coordinated dress codes ahead of time, so what gives? My wife is texting me to take off my jacket. I should have been more dressed down. What can you do? So thank you so much for hosting me, to Ilan and Bernice, and to the rest of the panel for inviting me to join this esteemed panel of mentors and colleagues. Certainly as the youngest one here, it's an honor. And I'm happy to share with you my perspective, or the cardiac perspective, on COVID-19, and try to squeeze it into 5 minutes. To start off with here, I included some pictures of some time volunteering in Israel. I used to joke that if I didn't get into medical school, I would just give up and become a shepherd and sit on a rock somewhere. So there's a picture of me when I volunteered with Magen David Adom, living the dream. Next slide, please. This is another picture when I volunteered with Save a Child's Heart in 2009. This is me in the operating room at Wolfson Medical Center trying to figure out how a heart-lung machine works. Next slide, please. So to begin with, I think more important than even talking about the cardiovascular complications of COVID is to remind everybody that despite the pandemic that's going on, it's important not to forget that our acute care services are definitely open for business, and to remind you all of some of the common symptoms of heart attack and some other cardiac conditions, as I've listed there. Next slide, please. What we found, just based on the raw data, that in March and April, when comparing to the same set of weeks over the prior 5 years, was that the overall death rate, and that's not attributable even to that's excluding the COVID patients, was significantly higher. And the best theory for that is that people were staying home with their acute cardiac and other conditions, rather than perhaps risk going to the hospital. And we've seen that death rate was particularly skewed in the older population, particularly those over 85. Next slide, please. And next one after that. So people often ask, what's my risk of COVID? And the first question usually that comes up is what's my overall risk of catching the disease? Am I at higher risk because I've got cardiovascular disease or something else? And the short answer to that is people's risk of catching it is pretty much the same whether or not they've got cardiovascular disease or other risk factors or not. The same principles apply in terms of physical distancing and hand hygiene and all of those important things that we hear about from Dr. Bonnie Henry. Next slide, please. The more complicated question is, what's my risk of complications if I do have cardiovascular disease or other risk factors? And that's a bit different. So we know based on the literature that's out there so far that people who have cardiovascular disease, that is that they have a history of a heart attack or heart failure or other arrhythmia, are at risk certainly of hospitalization if they do catch COVID. They're at higher risk of admission to the intensive care unit, of developing cardiovascular complications of COVID, and even dying more. And we've seen that pretty consistently across literature. What we've also seen is that patients who have risk factors for cardiovascular disease, that means high blood pressure or hypertension, diabetes, and obesity, are at similar risk of complications. The question comes up is, what's the connection? If I have hypertension, is there something about my hypertension that puts me at risk? And that may be. At the same time, we know that people who have these conditions are also typically older, and that in itself has been shown to be associated with more complications. Unfortunately, at this point, there is no one intervention aside from all of those usual common sense and other public health interventions as far as reducing the risk in this circumstance. Next slide, please. The next question that frequently comes up is what about my cardiac medications? And there was a lot of media attention devoted towards non-steroidal anti-inflammatory drugs as well as so-called ACE inhibitors in terms of causing worsened outcomes and interacting with this virus. However, in the research that's come out thus far, that connection is not really all that clear. There was one small study in rats that showed worsened outcomes, but we haven't seen that in humans. And to that extent, the Canadian Cardiovascular Society and other international bodies have come out very clearly and said that cardiac medications such as aspirin, ACE inhibitors, I've listed ramipril there, but there's many, angiotensin receptor blockers, or more advanced medications such as Entresto should not be stopped out of concern for interaction with COVID or causing complications from that. And in fact, if you're taking that medication, it can be extremely dangerous to stop those medicines purely for theoretical risk. Interestingly as well, there seems to be some evidence that statin medications may even be protective for patients who are acutely ill with COVID-19. Next slide, please. So what are some of the complications associated with COVID? I don't know if your screen is like mine, half of it might be cut off, but the common complications that we've seen so far is that COVID can cause what looks like a heart attack or damage to the heart that can mimic a heart attack, although by a different mechanism. We've also seen inflammation in the heart muscle, which is called myocarditis, as well as heart failure and even shock. There's probably a lot of different mechanisms from that, both from inflammation that's caused from the disease and low blood pressure, as well as some theories about higher risk of forming blood clots that can predispose people to this condition. Next slide, please. Whoops, can you go back one? There goes the punchline, eh? Anyway, a condition that's coming out a bit more in the literature is the so-called long hauler syndrome. And these are patients who have been through the acute phase of the illness and then spend up to many months potentially with symptoms of breathlessness, chest discomfort, feeling faint and racing heart. We're learning more about this condition, but it may be related to the autonomic nervous system and some other complex mechanisms, but we're seeing this more and more. So that's sort of COVID in the heart in a nutshell. Clearly, that raises more questions than answers, but hopefully as we learn more about this condition, we'll be able to find out ways of mitigating the risk in this illness. The next slide, please. So this is an example of inadequate physical distancing. This is from 2009 when we did a photo exhibition for Save a Child's Heart. That's Dr. Tommy Gershman and Mr. Trudeau, who happened to be there. With that, I'll pass the floor back to Art, and thank you for your attention.
Well, Josh, thank you very much. just before, we will not be political, but I know that Mr. Silver is in the audience, and we did invite Stephen Harper to join us on the panel tonight. And as you know, we do have a project named after him in the Hula Valley. Josh, also reminding our participants to chat their questions. We do have a question that is related to myocarditis, and so I'm going to work backwards while you're on the screen. And the question is, what's the risk of the incidence of myocarditis? And the question was in young men, and I'm not sure what how you want to answer that as far as the age cutoff, but how risky is it to have myocarditis if you do get COVID?
So far, we've seen that risk is actually fairly low. And I take a step back here. When we talk about things like myocarditis, particularly in young people, we're talking about a rare manifestation of a somewhat rare illness. And so at that same time, it's something that makes lots of waves. And we hear of a 20-year-old getting sick with anything, immediately that grabs attention and makes all of us naturally worried and concerned. But I think it's important to take that into the context of the common flu. So we know that the flu and other viruses can cause myocarditis in general, and we see it from time to time in the hospital, and in certain circumstances, it's quite severe. And I think that would be the same approach when it comes to COVID. Certainly not to downplay the importance and the contagiousness of the illness, but we're not seeing it all that commonly. And in terms of risk factors for that, it's difficult to tell. I mean, it's become that uncommon, at least from our perspective now, that there isn't any clear indicator that we can say, well, this 24-year-old is going to get it or not.
We have another question that, although it was directed to you, I'm going to direct it to Saul, because it says, why is the incidence of myocarditis so high in healthy young athletes? I'm not sure if that was in reference to COVID or just in general. Saul, do you wish to comment if that is true or not? Is myocarditis a high incidence in healthy young athletes?
Yeah, it's a hell of a good question from a very informed person, Josh Kleiman. Yeah, there was a little bit disconcerting, Art, was that there was a study done of young athletes where they had COVID, and during the time they had COVID, they had no cardiac symptoms with their COVID. So it was purely respiratory or viremia kind of symptoms. And they decided in a study format just to do an MRI on them just to check. And they found that a significant number of them actually had evidence of myocarditis, despite the fact that they didn't have any symptoms. It was quite disconcerting. We haven't reproduced that data, Josh. We don't know why it was so high in that population. Don't believe there's anything particularly about athletes that would make them more likely to have myocarditis than not. But it was disconcerting. We're trying to work out on a societal level, and you can imagine the money involved with sports teams in terms of who can go back and play after they've had myocarditis. This is big cash.
Mm-hmm.
And these are people's livelihoods and the enormous amount of money. And trying to work out who can go back or who couldn't. And that study really threw a spanner in the works because it suggested that people had no symptoms yet could have it. We all know about a lot of good athletes who have got COVID, pulled out of the NHL, pulled out of the NBA, that kind of thing. And it's an area of active study.
Thank you, Saul. I have a question for Dr. Laksman, and I guess it's related. It's atrial fibrillation. It's thinking about my friend who had ablation. Maybe you could tell us a little bit, what is ablation, and how effective is it if I have it from you, and how long will it last if you're trying to convert me from an atrial fibrillation to a regular beat? Dr. Laksman.
So wonderful question. It really does come back to a very personal conversation about your heart health with your physician. I can give you some percentages, but there's a lot more that we can understand about an individual to try to predict, are they going to benefit? Is it worth the risk? But in general, if you have atrial fibrillation and it's detected early, then the success rate after an ablation is about 70%. That's that you will not have any atrial fibrillation. Some studies are 5 years, some are 10 years, and that's off of medications. And then a second would be a success rate of 85%. But some people with more advanced disease, and that's described in lots of different ways, the success rate may be as low as 50% even after 2 procedures. Now, those numbers are much lower than we would like them to be, but even more disconcerting are the numbers when you relate that to medication. So the success rate of medications only after 1 year is about 30% of keeping people in a normal rhythm. So we obviously have a lot of work to do.
Thank you, Zach. I have a question that I guess I will handle, and it is, what about that test that I have to wear the blood pressure cuff for 24 hours? I'll answer that, and I guess as a bit of a, I guess, disclosure. I'm semi-retired and I work for Life Labs part-time. But sometimes there's situations you've heard of white coat hypertension. When you went to the doctor's office, your blood pressure was up. Conversely, I used to have a patient who was a doctor, and every time she came to my office, her blood pressure was normal. And yet I knew that she had high blood pressure driving across Lionsgate Bridge, working in her office. What she had was called masked hypertension. So sometimes if we're not sure of what is a true blood pressure reading, it's worthwhile either through your doctor's office or Life Labs or some drugstores to have this ambulatory blood pressure, to wear this blood pressure cuff for 24 hours. It measures your blood pressure every hour during the day and every half hour during the night, or half hour during the day, depending on the equipment. And it really gives us a truer reading of what your blood pressure is when you're at home, when you're driving, when you're relaxing, other than the 8-minute visit in the doctor's office. Bernice, how are we doing? We're nearly at Rad Hayom. Are we?
Yeah.
We're okay. So,
do you have any more questions at all? Did you get?
I think we are good, and I'm now ready to pass it over. And once more, I will just say that I'm so impressed. We had as many participants here, 100, as all of University of British Columbia Grand Rounds that was beamed all through the Vancouver Coastal Health Authority. And Doctors Isserow, Laksman, Wenner, you guys are great. This is we should go on the road show. It was fantastic how much information you gave in the limited time. Thank you so much, and thanks, JNF. And now I'm turning it back to Bernice, please.
Well, thank you. What an amazing information, like so informative. Thank you very much. I'd like to thank our panel of doctors, Dr. Saul Isserow, Dr. Zach Laksman, Dr. Joshua Wenner, and our moderator, Dr. Arthur Dodek, for taking time out of your busy schedules. I know you guys are very, very busy. JNF Pacific Region has partnered with Save a Child's Heart, SASH, an international humanitarian charity bringing children from developing countries to the Wolfson Medical Center in Holon, Israel. These children with congenital and acquired heart defects have almost no chance of surviving to adulthood in their native countries without the help of volunteer doctors, just like these doctors. Please turn your attention to the video.
When you're too in love to let it go, but if you never try, you'll never know just what you want.
When they get here, they see how much Save a Child's Heart care about them, and they get the help, so the fear disappears. And at the end of the day, they see that we all are people and human beings.
We are very thankful. Save Child's Heart brought my happiness to my family, to my heart. Thank you.
They are the calming voice telling us that everything will be okay every day. They make a difference in so many people's lives. Their bravery, skills, and passion is seen in the lives they have saved. Thank you for making this your goal in life. You're amazing human beings. Please make your donation using the link in the chat. And thank you everyone for joining us tonight in our JNF virtual Sukkah. It is such a pleasure not to get rained on in beautiful Vancouver. Good night, everyone. Stay healthy and stay safe.
Well, Joel.
שמשות זורחות, נשוב